All right, good morning, everybody. So I'm kind of like sticking out like a sore thumb in this session. We're going to switch gears to spine surgery, and I think the impetus for this lecture was because a lot of people ask the very simple question as to why do we do what we do? You know, why do we do a front versus a lateral versus a posterior approach to the spine? So I wanted to just go over the very basic principles of sort of the whole gamut of stuff that we do. So my one disclaimer is that I talk too fast, and the second thing is I try to cover too much stuff. So I already know that, and I apologize ahead of time. The decision-making process is quite complex in terms of what we have to do. Patient selection is a big factor. Surgical considerations, what do we have in our armamentarium to approach the patient? Some of the technology in the spine. I'm not going to cover technology too much, and I'm not going to cover economics too much, but these are definitely factors now more and more starting to affect how we make our decisions, how we take care of patients, as you all know, with healthcare changes that are going on. But patient selection is obviously the most important task that we have to look at, but it's not only the most important, it's also the most difficult task. Because what we do from a technically perfect operation in a wrong patient will essentially fulfill what we do from a surgical goal of the procedure, but it's not going to necessarily resolve the patient's complaints or deficits, in which case that can be considered a failure. Okay, even though we're walking out of the OR, slapping ourselves, high five, that it went great, it's not necessarily matching what the patient wants. That can be a failure. And so there's a lot of challenges that go into that. There's third-party pairs and cost containment. We have to look at those things. There's defensive practice strategies. We have to ensure that we're increasing the patient's quality of life, at least maintaining or if not improving. We have to ensure that there's patient satisfaction and hopefully improving patient satisfaction. And the problem is we don't have good historical scientific data to look at. Spine surgery is a little bit like the Wild Wild West. We have a lot of case studies and case reports. We're now getting better with the science and literature that we have, but we don't have a lot of good historical scientific data to look at. And oftentimes our surgical goals are typically fourfold: achieving good neural decompression, stabilizing the spine, if there's any deformity, correcting that deformity, and then I always put improved pain with an asterisk because you have to be on the same page, what I was alluding to earlier, with the patient in terms of what is your outcome and goal for pain control after this procedure. You cannot necessarily expect a patient to have 100% pain control with a focal surgical procedure. We all suffer from back pain. 80% of the population suffers from back pain. It's the number 2 reason why we go see the doctor. If I operate on you and you come back in a year and say my back hurts, well, that's not necessarily my fault. It's probably just more of how we are as people. So improve pain, what degree of pain? And typically my goal for pain control for patients, I'll tell them, is 60 to 70% in the OR. That's what my goal is, because we all suffer from back pain. So you have to make sure that you're on the same page as your patient. And once a decision is sort of made to pursue surgery, we have to define the goal of the procedure and what is that course that it's going to be to obtain that goal. Again, making sure you're on the same path as your patient. That's really key. We have to rely on our personal experience, what's worked in the past, what hasn't worked in the past. You have to use common sense and judgment, okay, not what other people tell you, but what is the sort of the sixth sense or the pit of your stomach telling you. You have to understand biomechanics, and I'm going to go over biomechanics quite a bit in a little bit. And then scientific data, what kind of literature is there to guide us in our principles? And this is true for all of the sciences that we do, and like I said, it's getting better. This is called the learning spiral, and this is sort of how we achieve our sort of training to becoming sort of the master of what we do in life, and whatever that is. You take the baseline sort of knowledge that you come with into a situation, you take the raw data that you have, the basic science, and you start to apply those principles to the patient and the situation, turn it into a clinical application. Okay, people are people, they're not textbooks. And then the last part of it is experience, and you just keep building on your experience. What has failed, what has been successes for you in the past, and you continue to use that and mature as a person, as a surgeon, and that's where the art of the medicine comes into, okay? Technology in the spine, well, there's obviously, and we have a lot of wonderful support from our vendors and things like that, and technology is rapidly increasing in spinal implants. You know, for spine itself, we've had such a dramatic increase in the technologies available to us. The only difficulty is that we don't know all of the efficacy of the technology that's out there. So that's always the danger. People come to you with the Google search page of, here is this implant, can you put this in me? Or why can't I have this? Well, you always want to make sure that it's efficacious and it works before you just go jumping in. I'm all about new technology, but you want to make sure that's good. So what we should, the directive for the surgeon is that we should not formulate our surgical goal on how we can use a technology to benefit the patient. We should rather do what is best for the patient, determine when that technology that best achieves that goal, okay? It's the flip of what we're talking about. But success can really only be achieved by putting together the pieces of the puzzle sort of accurately and successfully for a patient. And there's lots of factors and considerations for what we have to do. If we're looking at the patient, what are their complaints when they walk into your office? Do they have a focal radiculopathy or pain? Is it my arm hurts or my right leg hurts? Not only is it that, but is it acute versus chronic pain? I had a patient come to me yesterday, and he sat down and he said, I'm here for low back pain. I said, how long have you had low back pain for? 30 years. Okay, so why are you in my office today? Well, my deductible is going to run out next month, and I got to get this fixed. I said, well, okay, but you know, I don't think I'm going to be able to fix you in a month and a half for 30 years of pain. So we have to, again, be on the same page, but understand what is the goal for the patient and what are their complaints. Now, do they have neurological deficits? That's a different sort of ball of wax. Do they have weakness? Are they losing function? Okay. Anatomic issues. Is the problem in their spine, is it focal or is it a diffuse pathology? I'm going to go through a lot of case examples for the second half of my talk to sort of, I think, talk about and sort of solidify some of these principles. But do they have a single disc herniation? Or is it multiple levels of stenosis? Do they have kyphosis or abnormal posture in their spine that we need to fix, or some type of scoliosis? So we have to consider those factors from an anatomical standpoint. And then what can we do to address the problem? Is it going to be an MIS approach? Everyone wants MIS, minimally invasive spine surgery. Okay, is that the appropriate approach for the patient or not? Do we need to do major reconstruction to adequately address what your problem is, or simply do a decompression, take the pressure off, with or without a fusion? Is there some type of intermediate option or middle ground for us? Do we have to go all the way from the fusion of your head to your butt? Or can we go intermediate? Or do we just have to do decompression and get you being functional? So what's the intermediate ground that's available to us, or do we have one? And then, like I was alluding to before with sort of the learning curve, is what's the surgeon's comfort or experience? What has worked in the past that I've done that can work for this patient? What is in my toolbox? Okay, some surgeons are very facile with whatever approach, whether it's from the front, the oblique, the lateral, the posterior. Some surgeons are only comfortable with one approach. So you have to do what you're comfortable with as well. And then you always want to prepare. Don't react to a medical and or post-surgical complication. Okay, prepare for it. What's the, prepare for the worst and hope it goes the best, right? That's always sort of the mantra. You always want to be prepared for the worst, and do unto others as you would want to be done unto yourself. Would you want to have a 6-level fusion in your back or not? If you're active, probably not. So put that into your mind and treat them as you would your family members. Very sort of basic spinal biomechanics. I'm going to go through some biomechanical principles that we have to sort of contemplate when we're considering patients. Now, the spine configuration, many of you know this already, so I apologize if it's too basic, but there is a natural curvature to the spine. There's 5 natural curvatures to the overall spine. We have segments that go from kyphosis to lordosis to kyphosis to lordosis, so it's a nice sort of S-shaped curve if you're looking at the patient from the side. If you look at them from the straight front, they should have a very straight spine. Okay, so that's very important. So lordosis and kyphosis are normal aspects of anatomy, and they're very important to the proper functioning of the basic spine. If you look at somebody when they're standing upright, the normal adult spine is balanced over the pelvis. Okay, it should require minimal workload to stand upright, and that means that it's not a lot of work on the muscles to support that structure. We talk about a plumb line, and typically what that is if you were to drop an actual line from the patient, looking at them from the side, here, and you drop a plumb line from the cervical spine, it should fall naturally just in front of the pelvis, or on the L5-S1 space. If you were to do it from them standing in the middle, and you drop it from their nose, it should fall between, within the sacrum. Okay, that's a normal curvature. Once you start getting outside of those aspects, you start losing your normal spinal balance, and this results in strain on the spinal muscles and then causes more deformity. Okay, in our field in spine, deformity begets deformity. Once you start down that pathway, deformity becomes more deformity. And not only that, but they've actually done studies, some very elegant studies showing that the amount of strain and energy required to walk in an upright position, if you see old people walking like this, is tremendous on the back muscles. It can cause a lot of fatigue and pain. Just imagine that all day long trying to keep your head up with your back muscles. So this is a very important principle, and they're also showing that the more you can fix these problems when you're considering surgery, the less chances are probably that it's going to fail also from a hardware standpoint, because you can neutralize this, okay, reduce the forces on your implantation and hardware. So some basic sort of biomechanical principles. Well, it's important for us to understand the anatomy. inside as well. Okay, let's delve down to the anatomy of what we're trying to fix. Well, if we look at sort of these very good studies that have been around for decades that were done a long time ago, if we were to look at it in just the basic anatomy of the bones, the width and depth of the vertebral bodies, including the height of the vertebral bodies, increases as we go down in the spine from the head to the feet. Okay, so they start small and get bigger and bigger and bigger in general. That's what these curvatures are showing you. We also have to know anatomy and material properties. So the orientation of the joints and the shapes of the vertebral bodies also change as we go from the cervical to the thoracic to the lumbar spine. So not all the bones are the same, and they don't look the same. They're all designed differently to provide us with different levels of motion. We have much more motion in our neck, much less motion in our thoracic spine, and less motion in our lumbar spine. And the joints are designed in a particular orientation and fashion to accommodate those rotations and motions. So they're not all the same. And we have coupling motions, okay? That means that when one aspect of a spine flexes or extends, there's slight rotation as well. It's not always in one plane. It's one axis of motion causes another axis. That's called coupling. So you have to understand those axes of motions as well. And not only that, but the material properties of the spine itself, obviously, as you can think about, they get stronger and stronger and stronger as you go from the cervical spine to the lumbar spine. That's important in terms of what is the ability for the spine to sustain the hardware that we're placing, sustain fractures, things like that. So they get stronger as we get lower into the lumbar spine from the cervical spine as well. And then you have to also look at not just the bones, but the ligaments, the muscles as well. Okay, there's a lot of ligaments that are the supporting structure. These are like the supporting players in a football team. Okay, you have the quarterback, but then you have all these other things that are really important key players. There's lots of ligaments, small but very strong, that also help support between bones. Okay, that travel all the way from the head down to the sacrum. Some of them are within just the spinous processes, so the interspinous ligaments. So I didn't list them all here because there's lots of them, but you have to understand whether or not they're disrupted, whether they're thickened, whether they're properly functioning, because that also will play into the actual motion of the bones as well in relation to each other. With regards to the muscle, you have to understand the morphology and the geometry as to how the spine moves, and whether their effect is direct or indirect on the actual on the actual movement of the spine. And the muscles provide stability by virtue of the orientation of their attachments to the spine. And these are just two quick examples. This is from the back and this is from the front. There's direct attachments to the spine and there's indirect. When you have to rotate, you have your oblique muscles. When you're having to bend forward and back, there's the erector spinae muscles and your abdominal muscles and things like that. So you have to understand how these are playing into the overall motion. So some of these muscles will influence the spinal movements directly or indirectly and provide supporting structures. And finally, just going right back real quick, because I kind of alluded to this before, the bone quality itself. What's the ratio of the cortical to cancellous bone? What's that ratio? Because that's important for us when we put a screw in. Okay, you can't put a screw into butter and expect it to hold. You got to put a screw into something like wood. It's got to be strong to be able to resist pull out. Otherwise, that screw will just pull out and you'll have a problem. And this is for considerations for fusions or implanting any type of interbody spacers. You have to have a fundamental knowledge of physics. Now, physics is the most fundamental of all sciences, but it's physics and kinematics, and our physical therapists understand this very well. Physics and kinematics cannot be separated. The discussions of each is obligatorily, and that's a real word, intertwined with each other. And so in terms of physics, we have to appreciate what are the actions and reactions of the patient and the body. What are the reactions and actions, okay? What are the force vectors? What are the forces that are applied to a patient, okay? When they're moving, running, doing their activities, and what are the kinds of deformations or deformities they can cause within the spine itself. Because if you go beyond a certain, everything has a deformation curve in terms of a bone. If you're deforming anything and you get to the point where you stress it too much, it'll actually deform it as opposed to reacting and going back to what its normal shape was. And the knowledge of kinematics, we have to understand the study of motion of rigid bodies and those physical principles. So these are all, again, it's not just the anatomy itself, but how are we reacting to our environment as well. The instantaneous axis of rotation is the IAR. It's one of the things that we define, and essentially what this is how we move. Okay, when we bend forward, the IAR in this example would be defined right here in terms of the overall motion of these segments of the vertebral bodies. Okay, when you actually flex yourself, the IAR is not in a static single location. Okay, the instantaneous axis of rotation, as you flex this part of the spine, it actually moves back. This is an important principle when you're considering motion-sparing devices like an artificial disc and things like that. Okay, so And I'm going to show an example of that later. But so it's also important to understand how the spine flexes before you put a device in that's going to replicate that motion. Okay, so you can't just go sticking in motion devices and saying, oh, I'm going to preserve motion. It's got to be fairly normal motion before you can put a motion device into there, okay? Or you're going to have a problem, and that device will fail. This slide is meant to put you guys to sleep, okay? I'm not going to go over these principles, but essentially section modulus, stress, momentum of inertia. I mean, these are all essentially concepts that we have to understand spinal implants and spinal instrumentation, and how they work together, okay? These are indicators of the strength of an object like a rod or a screw, even the bones and things like that. And the reason why I put this up here is not to memorize this stuff, but we also have to understand what the devices are that we're putting in, okay? The difference is a screw is not a screw is not a screw. We always say a screw is a screw is a screw. It's not. There's screws, as an example, this screw right here on the top has a constant diameter, okay? And this one here has one that changes and increases in size as you go. Now, if you start deforming these screws or putting them under stress, their failure points are different, okay? This screw, as you can see here, if you don't understand the principles, will fail at the junction where the screw attaches to the plate, in this case in the cervical situation. This screw fails in the midpoint, okay? And you have to understand, so, and there's different materials also. There's cobalt chromium, there's now titanium, all those kinds of things, and they're different rigidities and different principles. So they have different failure points, but you also have to understand what the instrumentation is. So it's not just a matter of, oh, I'm just going to put this in there. You know, if you're doing a really rigid fixation in a patient, you want to consider more of a rigid sort of titanium versus cobalt chromium. So you want to put the appropriate metal in them as well. So these are other principles we have to consider. So I hope I'm not getting into too much detail, but there's a lot of sort of factors that you have to consider from a surgical standpoint before you just go and say, oh, I'm just going to do this. But let's get on to the patient factors and considerations as well. So the first question is, can the patient tolerate the required treatment that you're offering them? Can they tolerate that? Okay, are you going to put them through a 12-hour surgery and they're going to die? That's not good. What are their psychiatric issues? Do they have secondary gains? You know, we do know the research that people who are workman's comp, things like that, don't do as well in terms of their overall recovery after surgery. They have a very poor overall recovery compared to a standard person, because they have secondary gain issues, or somebody that comes in after a car accident that wants to get their back fixed. You know, there might be financial gains for them. So you have to also consider those in the factors before you take somebody to the OR or operate on them. Age, I'm going to go over that separately because that's getting to be more of an important thing. But other medical conditions, cardiac disease, you know, are they on blood thinners? Are they on aspirin, Plavix, Pradaxa? They just had a stent placed last week and they can't be on blood thinners for a year. Well, that's got to be very considered, you know, very seriously before you take them to the OR if they have to be off blood thinners for 1 week to 2 weeks. And next thing you know, their stents are now clogged. So that's important. Or are they having such bad cardiac disease that you can't even really identify what their neurological issues because they can barely even ambulate? Then they start getting chest pain and shortness of breath, and they're not really able to tell you, oh, I have to stop and rest. And you're either thinking it's claudication from their spine or the fact that they actually have such bad CHF they can't even function. Diabetes, you know, this is always tricky when you're looking at somebody and they come in and say, I'm getting numbness and tingling in my feet, in my hands, and it turns out they have bad peripheral neuropathy, and you're thinking it's actually coming from spinal stenosis in their spine, and you fix your stenosis and you find out they have continued ongoing neuropathy. Doesn't mean that you can't take somebody with neuropathy to the OR, but you have to have realistic expectations. And they come back and say, my hands are still numb. You say, well, yeah, you have diabetic neuropathy. So oftentimes we send patients to our colleagues in neurology, get an EMG, and they confirm they have polyneuropathy. Fine, you put that on the table, and you say you have neuropathy, but we can still fix your pain or your weakness. So again, identifying properly what are the patient's symptoms prior to getting them on the table. History of cancer. A lot of people have cancer, and they're on immunosuppressive drugs. Doesn't mean you can't operate on somebody, but you have to consider that in terms of wound healing. How are they going to do with their fusion inside? How is their wound getting healed? You know, if they're undergoing radiation or chemotherapy right now or things like that. Obviously, you don't want to do anybody that's actively being treated for malignancies. But people with cancer develop spinal compression fractures, spinal cord issues, so it's not always an elective procedure. Sometimes your back is against the wall and you have to treat them. But how is it going to affect their overall complication rate? Spinal infections, too, goes up. COPD, people that take steroids. Steroids, we know, will affect the ability for the bone to fuse. Somebody's taking chronic steroids, that could be a real disaster for you. Their wounds may not heal, they may not fuse. Rheumatoid arthritis, in and of itself, is not necessarily a bad factor. They can have more degeneration in their spine. But again, for a lot of these people, they're on methotrexate, or when they have a flare-up, they need to take high doses of prednisone or steroids. So you're always trying to wean them off their medications as much as possible before you take them to the OR. Again, for the same reason I was speaking of, fusions, wound healing, all that kind of stuff. And then congenital anomalies, I'm not really going to go into that, but sometimes people have spina bifida, things like that. You have to really know what you're getting into prior to getting into the situation in the OR. Again, preparing, not reacting to a situation. Aging is a really important sort of factor that we're seeing more and more. The population's aging, we all know that. They're not as accepting of limitations from previous generations. We have a much more fit and active older generation than we used to. And just saying that, oh, you're above the age of 70, we can't touch you anymore, doesn't work, okay? We routinely operate on people, shockingly, in their 70s, 80s, and even 90s. I hear from my orthopedic colleagues, they're operating people in their 90s. That's a realistic age now. And the symptom complexes are different as we age, okay? Stenosis is a very common presenting etiology or pathology for these patients. They start to have loss of normal lordosis and more kyphosis, okay? Gravity will always win. They have more comorbidities, osteoporosis, and their overall reserve physiologically is decreased from their lung capacity, heart capacity, all those kinds of things. And you have to balance the benefits and the risks in these patients before taking them to the OR. Unfortunately, we don't have tons of literature. We're starting to develop a lot more literature on aging patients as well. The overall outcomes can be very good and comparable to our young patients, but unfortunately the complications are much higher. So you have to be prepared for that and have that conversation in the office. And again, their overall outcomes have to correlate with their preoperative expectations. I keep putting this in my talk because it's really important. Can't even stress that. And I think that really helps with postoperative expectations matching what you discuss in the overall expectations of the patient preoperatively. Diabetes, a lot more of that going on, but then dural tears, the dura lining of the spinal cord becomes very thin as you get older. Much more high propensity for dural tears to occur. Other factors, nicotine use and obesity, I'm going to touch on those two as well individually. Trauma, which I'm not going to go over, that's a whole different ball of wax, but do they have patterns of instability before you get in there, okay, as opposed to your elective patients? Have they had prior surgery? You do a lot of revision surgery. Somebody's had a laminectomy, something is scarred, or they have a prior infection or a CSF leak, and now you got to go back into that space. Sort of drops in the pit of your stomach. Post-surgical issues, what's their support network like? So now you have to go from the surgical time to the post-surgical time in terms of their outcomes overall. I had a patient that had surgery, and while he was in his recovery in the hospital, he was a renter in a house. The guy sold the house, and he didn't have a house to go back to, okay? How do you think that patient did it? I mean, it was terrible. He had to go to a nursing home. He was in his 40s. So your support network is really important for your outcomes too, emotionally, and be able to do all the resources, rehab, physical therapy, things like that. You can't just do this big major reconstructive surgery on somebody and dump them in a nursing home. They don't get the care they need there, okay? Immobilization, this is always debatable how people treat this, but putting a 90-year-old in a collar, what do you think their chances of falling? Probably pretty high when they can't look at the ground. But choice of bracing, not bracing, those kinds of things, it's all over the gamut of spectrum of things that people do. But sometimes that can be a consideration. Will they be able to tolerate being in a brace for a large rigid brace, being able to put it on again? Part of that is a support network, somebody to help them do that at home. So nicotine, we know that the rate of non-fusion in smokers is twice that, okay, of non-smokers. That's really important. So the rate of non-fusion in non-smokers is about 5 to 15%, and smokers is about 20 to 30%. That's pretty high. And unfortunately, a lot of people do use nicotine. It's not just smoking, but it's the nicotine product itself. And the reason is we have poor bone growth overall. That's because of the vascularization of the bone starts to decrease. Some theorize that it's an anti-inflammatory itself, like a medication. But it also does increase the rate of disc degeneration. That's one of the factors we do know scientifically that increases the rate of disc degeneration, and can also cause other health factors, as you know, cardiovascular issues, pulmonary issues, again, going back to the whole gamut of what the patient is like before they end up on the operating room table. Morbid obesity is defined as a BMI of 40 or greater, 100 pounds overweight or 50 to 100% over their ideal body weight. This is becoming more and more realistic and problematic in my clinics. Complication rate, unfortunately, goes to about 13% from about 7% in a standard patient, okay? This is typically related to lung complications, wound healing, heart and kidney issues as well. It's theorized that morbidly obese patients have a higher overall average hospital cost of approximately $20,000 per hospital admission. And the reason is typically attributed to longer hospital days by about a day to a day and a half. And unfortunately, their overall risk of death and their mortality rates compared to a standard patient is almost fourfold. It's 0.5 versus 0.1%. Okay, so very serious considerations when you have morbidly obese patients come into your office. But we are seeing more and more of them. It used to be go home, lose 50 pounds, and come back to my clinic. That doesn't work anymore. Okay, it's increasing. It's real. Just have to deal with it. Okay, we're getting bariatric tables, we're getting bariatric sets, and we just have to be prepared instead of reacting to the situation. What are your surgical options? Okay, there's fusions, there's non-fusions, and there's motion preservation. Fusions can be either instrumented or non-instrumented. Typically, we're talking about instrumented means we're placing hardware, pedicle screws, hooks, things like that, versus a non-instrumented. A non-instrumented fusion means that we're actually just going to lay down bone. We're going to rough up the bone and lay down bone. That's considered a non-instrumented fusion, but still a fusion in and of itself. Typically, you can use neutral hardware like interbody spacers, like I was talking about as well, or do osteotomies where you're actually cutting bone out to shrink the back part of the spine. You can augment it with cement as well, but the important thing is to overall alignment should be, probably the most important thing is meticulous attention to overall alignment to the patient. You don't want to put them out of balance, which I'll talk about in a second. But if you are careless about what you're doing with your hardware, just putting in hardware is not a success itself. You need to put in hardware, but you need to do it properly with all those principles I was talking about earlier. Why would somebody get a non-fusion? Well, it's a minimalist approach, which is always good as well. It's not a bad option, or a good option sometimes with scoliosis. Sometimes if you have somebody with scoliosis, you can consider non-fusion. Some people say that you can cause more issues by causing further foraminal collapse or rotatory subluxations. I don't necessarily agree with that. I think you have to pick the right patients sometimes, and I'll show an example of that. But there's different types of this you guys hear about us doing: decompressions, laminectomies, laminotomies, discectomies, foraminotomies. These are non-fusion surgeries. Okay, we're essentially decompressing the neural elements without any instrumentation. Motion preservation, this is like the hot thing that everybody's trying to do. We want to preserve motion. Remember, what I was trying to get back to with the IAR, the instantaneous axial rotation before, was that you have to understand what are the planes of motion that you're dealing with in the spine. You have to understand those principles. There's rotation, there's translation, there's bending, okay, in the spine, and there's coupling. When you flex your neck, you have a degree of rotation every single time. That's coupling. You have to understand that, and the device has to match those IARs or it's going to fail. You have to understand what the loading component is to the device, and you have to be able to replicate that IAR. That's what I was talking about before. And some people think that the adjacent level disease decreases by doing this. So rather than having a rigid segment of a fusion, once you start having motion preservation, you're not stressing the levels above and below the spine as much. So you start to reduce the rates of adjacent level disease. And that's really the big thing we're trying to tout out there. The FDA position as of last year, current clinical trials do not support that motion-sparing devices reduce adjacent level disease. That's really important to understand, because a lot of people think that it does. We're not sure. I think the jury's still out unless anybody disagrees with me. I'm not going to go through any of this stuff, but part of the workup, if you have somebody who comes in with scoliosis, of course we get the standard x-rays, CTs, MRIs, smilograms. Like I said, we send our patients to our pain physicians or to our neurology colleagues for EMGs, for injections and things like that. But sometimes one of the things that's important to get is a scoliosis set of x-rays. Somebody walks into your office like this. You don't want to get a focal lumbar spine x-ray. You want to get a 36-inch or a 3-foot standing x-ray to see what their overall balance is with their skull to their pelvis before you make a plan down below and you start altering the mechanics of what they're going to look like up top. So I'm going to just go through the cervical, thoracic, and lumbar spine with some quick principles and go through some case studies. I'm not advocating that this is how you treat every single patient, and some of these are from my fellowship as well and other cases as well. They're not all mine. But surgical approaches to the cervical spine: anterior cervical discectomy fusion, very common. Corpectomy fusion, laminectomy fusion from the back, laminoplasty, where we just do an open door technique, giving more room to the spine, versus a foraminotomy, or giving space to one of the nerves. So now I'm going to go through a bunch of case studies just as examples here. This is a guy that came in 45 years old, left-sided numbness, tingling, weakness, and his pain for about 5 months. He started having some difficulties, complaining of being off balance, and when he coughs and sneezes, he said, "It feels like my spine is quote-unquote separating." He had weakness in his left-handed leg, and he had some facial pain as well. He had medications, no improvement, and this was a CT scan and MRI. And what he's got is a problem here in the ventral aspect. This is his high cervical cord. Here's his brainstem here. He's got a pannus, or compression of the ventral aspect of his brainstem. Okay? So he's having brainstem situation here and spinal cord issues here. So the proper surgery for this, well, he underwent at an outside facility, he went surgery from the back of his head. They did an occiput to C4 fusion. They did a craniectomy, took off the bottom part of his cranium in the back and did a decompression and used BMP. This is what he looked like. He had a fusion in the back. He did well for a little bit, got a little bit better, and then 10 months after surgery, he had more difficulty with hoarseness in his voice, swallowing difficulties, and more gait balances. diminished gag. So now he's losing more function of his brainstem, and the reason is he's still got compression from the front. So you can't treat this problem from the back adequately. Sometimes you can, but in this case they didn't. He still has ventral brainstem compression and he's getting worse. So now what do you want to do? Well, you don't have a lot of options. You can't go back in from the back. What he needs is a transoral resection. You're going to have to go through the mouth and you have to take that piece out. Okay? And so we did an odontoid resection of the patient. We go in through the mouth, literally open his mouth, and the odontoid's sitting right there. You can actually feel it. And you open this up with your ENT colleagues, the mucosa, and you resect it. And that's it. And they get better. And so that's what he looked like afterwards. This is just a post-op image, but this is a little bit of grummus, but he got much better. Cervical myelopathy, we see a ton of this. A 74-year-old guy presented with progressive weakness and urinary leakage. He was using a wheelchair. He had lots of medical comorbidities. He relies on his left hand to be able to use his motorized wheelchair, but he was losing function of his hands, in which case he's essentially becoming a slow quad. This is his MRI scan. He essentially has no cord left, okay? This is the axial images. He has a very large disc herniation ventrally with no spinal cord. This is what it should look like. You can't even see it here. So we go into the front of the spine because the pathology is from the front, do a quick decompression, so an anterior cervical discectomy and fusion. So approach from the front. Somebody else with cervical myelopathy, she's 87 years old. She has a 3-month history of arm weakness. Same concept, losing function. She has myelopathy. She has spinal cord compression right here, but her pathology is actually from the back of her spine, and she's 87 years old. Above the age of 75, if you go in from the front, they have a much higher rate of dysphagia and swallowing difficulties. So just did a small little 3-centimeter incision, went in the back and did a small laminectomy, decompression from the back, and got out. She's doing fine. So again, the pathology dictated what we did. 71-year-old lady comes in. So these are all similar cases, but different approaches in terms of the surgical. So trying to give you a sense of why. She has same complaints, losing function. She has spinal cord changes in her neck here. And actually, when you look at her, she has kyphosis. She has focal kyphosis or curvature of her neck in the front. And actually, when you look at her, she's actually got a stooped head forward like this. So the goal here was twofold. One was to take the pressure off the spinal cord here, but also to fix some of her posture and get her looking back up at the horizon. So we took her to the OR, and this is what she looked like right in the OR in the beginning. Then we crank her open, okay, and push her back. And this is a corpectomy, so we took out 2 lobes of the bone, and you push her back. So now she's able to look up and be neutral. So expanding her neck from the front. And because her bone quality is so bad, we supplemented her from the back just because she had such bad osteoporosis. The 37-year-old guy who presents, he's got some arm tingling numbness. He didn't do a lot of conservative therapy, but he is an extensive smoker, 2 packs a day, and he's young and healthy. He's got normal motion on his x-rays, but he has a disc herniation focally in his neck right there, and so he's young. One of the best options for him to consider artificial disc rather than a fusion. He's young and healthy. They don't have to wear a collar, and they're usually back to their activities after a couple weeks. Artificial discs are much more challenging to do in old people with osteoporosis, no normal motion, so he's a great candidate for that. Thoracic spine, pedicle screws, hook placements, sublaminar wires, facet screws. We don't do a ton of thoracic surgeries itself. Pedicle screws are the workhorse of what we do. Sometimes you have to supplement that with hooks to prevent pullout for people with osteoporosis or to do cables and wiring. And this is a lady that came in, Dr. Nelson and I shared this patient. It was his patient, a 55-year-old lady with metastatic lung cancer. She had back pain. She bent forward, developed acute onset of back pain, developed a T6 compression fracture. She had a kyphoplasty where somebody injected cement into that bone. Back pain got better. This is what she looked like in 2009. She had a 25-degree curve. This is the fracture right here. She's not doing much in her life, but over the time, she's progressing. So over 2 years, she's got an adjacent level fracture with worsening compression. And this is her in 1 year further. So who wants to sit here and watch her go from a 25 to a 78-degree curve over 4 years? Okay, remember she's in her 50s. Nobody's going to wait for her to be coming in with a 90-degree curve. So Dr. Nelson and I took her to the OR. We did a corpectomy from the back, opened her back up, put a cage in, pushed her open, and then fused her, okay, to prevent further kyphosis and spinal cord compression. Sherman's disease, some people have heard of this, Sherman's kyphosis. It's a disease essentially where you develop this progressive kyphosis in the thoracic spine. It becomes a rigid curve in the spine. And most people have a lot of problems because they're essentially having difficulty with their breathing, and they have a lot of pain because they're literally kyphotic and walking around. They can't straighten it up. They develop a hunchback. This is a 36-year-old lady that came in. She was neurologically normal. She said she had scoliosis when she was a child. She had bariatric surgery because she was morbidly obese, but what she was having difficulty was lying on her back, because she'd lie on her back and she'd literally be posed up like a hunchback. Okay, she had difficulty, so she always had to sleep on her side, but didn't have a lot of pain. That wasn't her biggest complaint. It was really a cosmetic issue and sleeping issue, and so she had this very exaggerated kyphosis in her spine right here. Okay, she's young, and so she had to walk around life like a hunchback, and she didn't like that. And not only that, but she had a scoliosis looking at her from the front back as well. So what we did is a pedicle subtraction osteotomy. So you can go in from the front and extend the spine and lengthen it, or you can go from the back and shorten the back to essentially achieve the same concept. So we did a subtraction osteotomy from the back and pulled her back from the back, so shortened up the back, and then fused her and corrected some of her kyphosis. So this is what she looked like preoperatively, and this is what she looks like postoperatively. So the curve is still there. She has some of a kyphosis, but it's better. It's not as hunchbacked as it was, and a little bit more straight in terms of the overall scoliosis. This is what she looked like on the table before we left. This is her pre-surge, and then this is after surge. So she has more of a normal curve. It's still curved, but she is on a table to give her curvature, but it's much improved from where she was. Lumbar spine, I'm not going to go through these. I'm going to go through these sort of fast, but the A lift, P lift, T lift, X lift, axial lift, that's all sort of the going circumferentially around the patient. The A lift is the anterior lumbar interbody fusion. This is typically a trans or retroperitoneal approach. It can be used standalone or supplemented with posterior fixation. The nice thing is you can get a nice large graft in there, and you can really crank the people open and improve their overall lordosis. Problem is obviously you have to work around large vessels, and can cause, for young men, retrograde ejaculation. There's a rate of 5%, and that can be devastating for a young man who wants to have a family later in their life. Posterior lumbar interbody fusion, or a PLIF. It's a bilateral approach to the disc base. It's very familiar to a lot of surgeons. You can decompress the central canal. You do have to retract the fecal sac, which means for somebody that's older, causing possibly a dural tear or CSF leak. It's difficult to do in somebody that's had prior surgery if they have scar tissue, and the end plate preparation is not as good. Compared to a T-lift, where you're coming in more of an oblique angle, these are all coming in from the posteriors. This is a transforaminal lumbar interbody fusion. It's nice because you have less fecal sac retraction. You can get good end plate preparation. You can put a cage in there. You can do this MIS, and the nice thing is it works well in patients that have had previous laminectomies or revision surgeries. You're coming in from sort of a virgin plane through the joint itself, but you are working around the DRG of the nerve, so sometimes people can have increased pain after that surgery, and it's hard to work on the contralateral side sometimes. X lift, D lift, L lift, a lot of words, kind of similar concept. This is coming in from a lateral approach. These are all the trade names. Essentially what you're doing is you're going through the psoas muscle. It's nice because the incision is very small. You can get a very large graft into that space. You can do an indirect decompression by cranking open the disc space and opening up the foramina bilaterally. But they're working on standalones versus non-standalones. Sometimes they recommend doing posterior instrumentation, and it does get harder as you get into the lower aspect of the spine because you have the pelvic brim in your way. And sometimes there's actually more nerve damage that occurs as you start to approach L4, L5 because of the location where the nerves come out from the spine themselves. Axial lift is the axial lumbar interbody fusion, or some people have heard this as the wazoo screw. Essentially the patient is prone, you're coming up from the presacral space. This very small incision, it's very slick in terms of the overall approach. You don't have to do anything in terms of moving the patient. You can just keep them prone after you put this device in, and you can actually supplement it with pedicle screws or facet screws from the back. They have a device that was for 5-1 alone. I now think they have a 2-level device for 4, 5, and 1. The question is whether or not you get good disc preparation in the actual fusion itself. I think people are plus minus on that approach, but it does get done. So a couple quick cases for lumbar surgery. This is a gentleman with a bilateral pars defect. He had low back pain and right leg pain. His neural foramina are stenotic in the L5-S1 spaces bilaterally, and L5-S1 radiculopathy, but a pars defect itself. So you can't just necessarily do a decompression at this level because they are essentially unstable. He actually has a grade 1 slip. You don't see it on this MRI because he's supine, but when you stand him up, he actually slips forward into a grade 1 slip. So we took him to the OR, and we did an interbody fusion with a T-lift and then decompressed his nerves bilaterally. So that was a fusion decompression because of his pars defect. This is somebody that comes in with a grade 2 slip, a mobile slip of grade 2. These are kind of challenging to work on. He was a young guy. He did not want an anterior approach. And so you can see the overall slip of the spine here. And so that can be pretty painful. A lot of back pain, radiculopathy with grade 2, and so you do a 2-level fusion and pull them back using the L5 level and L4 as a bridge and pulling back into alignment feels much better. Now, I'm not necessarily you always want to do a 2-level fusion, but in this gentleman it worked very well. Adult degenerative scoliosis, we see a ton of this. These are the most challenging cases. This is an 82-year-old person that came for low back pain, leg weakness. She's very active. She runs a horse training facility, literally runs it. She runs with the horses when people are on it to train them. Okay, she's 82. She fell down the stairs 2 months before she came to see me. She was having progressive weakness in her legs and urinary incontinence. Okay, and she's weak when I see her. This is her MRI scan. We see this all the time. These are so hard to deal with. This is her from the front. She's got a lateral listhesis, okay, of the bone is literally slipping off. She's scoliotic, and this is her MRI scan, okay? She has stenosis at every single level in her back, okay? She also has a small signal change in her spinal cord up here at the conus, so that's probably the source of her urinary difficulty. She actually injured her spinal cord. So she has a 5 to 6 level problem here, and she's got scoliosis with lateral pathology. So what are you going to do? Do you want to just do a decompression with this? Or with the fusion? That's the challenge. So I actually did a fusion. She was extremely healthy. We had a multi-level fusion with interbody cages and decompressor. So we did L2 to L5 and a small lamine. She's doing fantastic. Her bone quality is actually better than some of the 50-year-olds I've seen. So I got lucky with this one. This is a gentleman that came in. He had 4 prior surgeries from me. He had a CSF leak, spinal infection, prior fusion from L3 to L5. When he got the infection, they took out his hardware. So he had unstable back pain, and he had this stenosis. He had claudication. He had a prior CSF leak and infection. Who wants to go back in here and do a redo decompression? So this is what a spinal cord looks like in the middle here, open and then closed. So what I did is I came in from an anterior approach with huge cages, indirect decompression. This is what he looked like pre-surgical. Here's his MRI immediately after surgery. So you can do indirect decompression. So it works. It's impressive from that standpoint. So, all right, which of the following is not a surgical goal? I guess cue the music. Whoa. Okay, I didn't do a good job here. Oh, none of the above. None of the above. Oh, sorry, they are all correct. I thought you changed my question. I'm sorry.
I did not.
No, Sagita, I thought you changed it. Okay, you're right. Good. Which of the following is critical to the proper functioning of the normal spine? Oh, 80s music. I like it. Okay, good. Yep, kyphosis, lordosis are important. We don't want to have patients with flat. Nicotine will half, double, quadruple, or increase 10 times the fold of rate of non-fusion in spine surgery compared to normal patients. Yep, it'll double the rate, exactly. And so why we oftentimes will try to get patients to quit smoking as well or get off nicotine prior to surgery, but sometimes you don't have that luxury. And this is the last question. Morbidly obese patients have what rate of death in spine surgery compared to their equivalent non-obese patients? Half, double, quadruple, or 10 times the rate? Yeah, it's actually, yeah, so we're talking about death though, not morbidities. So we're talking mortality. So the morbidity rate's twice, but the mortality rate's almost 4 times. So close. But good job. Any questions? Thank you for keeping me on stage.